Well, prior to that, we have discussed about the components of the mental status examination today. And now we are going to talk about the complete assessment sheet of mental status examination, right? So today we talked about what actually mental status examination means, what are the significance importance of this particular exam, or you can say the assessment in case of clinical settings, right? So we talked about different components, different steps of the mental status examination. Now we are going to talk about the complete assessment sheet here. Here is the orientation. That is the basic component in case of mental status examination inquiry. We talk, and then comes the sleep. You have to make sure to understand if the client has a very complete, intact patterns of the sleep time, like he used to sleep for at least 6 hours a day, right? If either it's broken or the client is having a very regular episodes of insomnia, having nightmare or sleepwalking, right? You have to make sure to mention that. In case if the child is facing the night terrors or the bad dreams, you have to mark that down. Then comes another thing that we talk, that is the attention, concentration, and the memory. You have to make sure to observe that component very well and briefly, where you have to indicate if the client has an intact memory or either it's broken. So here, broken doesn't mean the client would have some kind of vase and you have broke that. Uh, it actually means the client have a very irregular period of that particular objective construct in his lifestyle right now, and he's facing problem with that too, right? Apart from his presenting complaints sometimes. So then comes the perception. We have talked about this in our inquiry of the components. In case of perception, you have to inquire if the client is having an intact perception. Sometimes if he's not having the complete perception, then it means he's facing some kind of stimulus errors which are not present there, but the patient is perceiving them. And we have called them as hallucinations. So either it can be auditory, visual, tactile, sometimes somatic, sometimes olfactory. So it depends, right? And you have to record that. Then comes another thing, that is the thought patterns. We talked about it, right? We talked either it's about the form, it's about the texture of the thoughts, it's about the flow of the thoughts. So you have to make sure to realize if either his thought pattern is a bit suspicious, or they have some content of delusions there, or there is some kind of loose of associations in his thoughts right now, right? Sometimes his prior thought is not very much connected to his another thought. So in that case, you have to make sure to find out that particular pattern and you have to record that, right? If it's intact, you have to mark that in your record sheet here. Then comes affects. Affects is actually the synonym for the mood, right? So you have to find out if his mood is being depressed, if he's feeling, bit guilty right now. Is he having some kind of, that suicidal mood sometimes? Patients feel some kind of injurious behavior to themselves and they don't know how to express that. All right. Sometimes their mood is a bit hostile, right? Especially in case of adolescents having some kind of oppositional defiant disorders or something like that, patient used to face this, right? So either the patient mood is a bit excited, like agitated mood sometimes, or having a grandiose expression of the moods, especially in case of bipolar disorders. So you have to record that. Sometimes it's like a blunt expression. I don't know what I'm feeling right now. I don't know it's sad. I don't know I'm happy. I'm just empty inside. I don't know what is it. So it's not depressed, it's not suicidal, it's not crying, it's not grandiose, it's not excitement. It's just something is not there. It's just the jar of the mood is empty in the person, right? And you have to record that because there should be something there, but it's not there. So it's also an alarming situation, and you have to record that, right? Then comes speech. We talked about it in our talk content of the inquiry, where we talk if the clients way of talking is a bit talkative or having some kind of circumstantial talk, like he's talking about all other things than the topic, then it's circumstantiality, and you have to mark that down. Or either the client is having some kind of abusive speech towards you, or even for the others as well. But if he's using that kind of speech or that kind of talk during the session, you have to record that. All right. Then comes the motor, where we talked about you have to record, you have to find out, you have to observe when the client walk in your room until he's sitting to his chair. His motor skills are very much important for you. You have to write down if he was moving, a bit restless, if he's not able to sit properly, he have to stand sometime, he have to move his legs sometimes, or he's just, want to move. Sometimes patient just used to say, no, I'm sorry, I just want to move. I don't know. I just want to walk a bit. I just want to take a walk. So that means he's having some kind of motor functioning right now. Or either it's just retarded, which means, for example, in case of depressive patients, you would see this kind of situation where the patient would be just sitting there and he just don't want to move. So it means he's having some kind of retardation in the movement. His motor skills are being retarded right now, and you have to mark that down. Or either he's being excited, like we have talked about the manic patients. So in that case, they have a very agitative expression. They would be like full of energy on the go, and they would used to like walk around. They would be like screaming, they would be like shouting, or even talking a bit louder than the other person, right? So this is all about your observation. Okay, during the whole history taking, sometimes even it takes 2 to 3 sessions to record the mental status examination in the very first sitting. So it's just fine, but you have to record them very keenly. Then come anxiety. Anxiety is a bit like about his intensive expressions. Either the patient seems to be a bit nervous, either he was having some kind of phobias, all right, either he have some kind of obsession with something. For example, I used to have a case of a patient. He was 5-year-old male with the speech delay actually. And I found out the child was actually obsessed with one of his comforters. That's strange, but he was. All right. And over the period of time, when I took certain sessions, I found out actually he was obsessed with his that particular comforter because his mother used to tell her some fairy tales while he used to sleep, and he used to communicate during that phase with right with certain chunks of words. So that was actually his obsession. All right. So you have to mark that down. Then comes his mannerism, his posture, his general appearance, his general behavior overall, right? Either he was having some kind of unusual gestures, or either he was having some kind of, pervasive or preoccupied movements. So that is his general behavioral observation for you, right? That would be the whole summary till right now. Okay. Then comes if the patient have some kind of psychosomatic features. Okay, sometimes patient will be like, oh my god, I feel I'm a bit fat, right? Or I'm having headaches sometimes right now, right? After that particular psychiatrist who had prescribed me that particular medication, I'm having some kind of headaches, right? Or I'm having some kind of, even in female, sometimes I had a case recently and where the child or the girl was actually 16 years old, but she didn't have any onset of her menstrual cycle. So in that case, you have to make sure to mark that in the psychosomatic complaints. If the patient having some kind of asthma or any skin disorder, any medical history, or even sometimes vertigo, anorexia, there are a lot of other complaints in that particular episode with pain. You have to write that down, all right, in your medical records. Then comes if Sometimes in the rehab, especially, it's very much important to record the addiction assessment. Why is it so important? If the patient used to have some kind of narcotic use, even smoking, even chewing gums, right? Even some kind of alcohol use, even some kind of gambling. And right now, he is coming to us you for depression with a history of that particular usage. Then, apart from recording in the history of the prior medical or psychopathological condition, you have to write that down there because sometimes it can be undiagnosed relapse, right? So you have to make sure to observe that particular circumstantial situation there. Then comes its interview behavior. Why is it so important? It's so important for you because you have to indicate his silence, his resistance, sometimes his defense mechanism for you. So it would actually help you out to understand what should be the therapeutic approach for you for later sessions, right? So either you have to make sure to understand if the client is having some kind of open interview behaviors towards you, either it's secretive in the initial sessions, either he was so anxious to talk about, either he was relaxed or withdrawn. All right, withdrawn means the patient is talking to some extent after certain period of time, after certain remarks, he just back he don't want to talk anymore. So that means he's withdrawing, right? Then timid. Timid actually means being preoccupied to talk about something and just want you to accept that situation. So it's timidness, all right? Then come if his initial behavior was aggressive towards the therapist sometime, or it's complaining, or it's cooperative. So either whatever it's positive or negative or being neutral, you have to record that. All right. Then comes to identify his strength, all right, his degree of insight. Either the client was being a bit motivated, either he had some kind of insight towards his problem that he's facing right now. He knows that he's been admitted in this kind of psychiatric institute here. So, what is the reason behind that? Does he know that he is having some kind of problem, or he's just being, putting the whole scenario towards others that they made me do this? They are responsible for that. So what is his attitude towards his insight is very much important. His intellect level. Is he meditating, right? Is he actually having some kind of circumstances to support him? So these are the particular strengths you have to identify because they would help you out to identify his prognosis. All right. Then comes his overall psychosexual orientation towards himself. Right. It's a bit complicated than any other thing because either the patient have some kind of gender identity different to what actually he appears to be, either the patient is paraphilic, right? Paraphilias are a very complex kind of disorders or, related to the sexual desires that are being very much less discussed in different cultures. So I'm not going to discuss it right now, but these are the particular concerns you have to make sure to write it down there. Either it's psychedelia dysfunctions or the sexual dysfunctions, either it's being intact in case. Then you have to also record that situation. Then comes the personality traits. So in case of personality traits, you actually have to mark down his overall personality components. All right. You have to find out if the patient have the particular traits. I'm not talking about personality, or I'm not actually labeling about some kind of personality disorders. I'm talking about certain traits in the person. So sometimes disorder is not being so identifiable, but the patient have some kind of traits or tendencies right now, which are not so much eligible to actually mark him for that disorder. So in that case, you have to state that this particular disorder traits are being found, right? Either in case of personality traits, it's paranoid, either it's schizoid, either it's schizotypal, antisocial, or borderline, or histrionic, or narcissistic, avoidant, dependent, passive aggressive OCD. So whatever is it, you have to mark it down in your record. Even in case if you find it apart from that in any other, then you have to mention that as well, right. This was already constructed brief kind of mental status examination for you, and overall it stays the same. It's the standard assessment, and it's not actually an assessment, it's a behavioral observation pattern, and it stays the same overall worldwide, but just a bit different to assess sometimes, to use sometimes. They have just different branding, right? So this was for the day. I hope you guys enjoyed the lecture, and if you have any kind of question, you can just comment in our YouTube channel, or you can access our contact information. That is uh, themindsconsultant@gmail.com, or you can use our WhatsApp, or you can even visit our YouTube channel that is with the name of the Minds Clinics, and you can just comment there and we will be there to help you. Right? Take care of yourself. Have a good time. Bye bye.